Welcome to the Medicine and Science podcast from the BMJ. I'm Cameron Abbasi, Editor-in-Chief. This week, research on weight regain after GLP-1 receptor agonists. What happens when you stop taking weight loss drugs?
We found that people who took medication lost more weight compared with those who took part in a behavioural programme, but the weight regain was much more rapid after medication compared with people who had taken part in behavioural programmes.
We also look to Gaza, where new Israeli regulations on aid workers are making the work of medical charities like Médecins Sans Frontières much more difficult.
Even with the warnings from the Israeli army to evacuate the hospital, they were refusing. And I think that's ethically right. They cannot leave patients behind. I mean, not all the patients can leave and walk.
First this week, GLP-1 drugs. It's well established that weight regain is a common result after stopping GLP-1 drugs, even in trials and under experimental conditions. But new research just published on bmj.com aims to quantify what is happening in the here and now for patients who stop using these weight loss drugs. Navjot Lada, our UK research editor, finds out more.
My name is Sam West. I'm a postdoctoral researcher at the University of Oxford.
Thanks so much for joining us on this podcast today to talk about your recently published research paper, which has been getting a lot of attention because you're looking at weight regain after using weight loss medications, which is one of the hot topics of our time, really. For those of us working in clinical medicine, we've obviously spent the last few years marvelling at how effective these medications are at helping patients lose weight and, of course, manage diabetes, which is, what they were originally intended for. But you have been doing some research that's looking at the other side of the curve and what happens when people stop taking these medications. So why don't you tell us a little bit more about what you did?
So the new obesity medications, semaglutide and tirzepatide, are transforming the treatment of obesity, with people in clinical trials losing around 15 to 20% of their body weight. But what we also see is that around half of people discontinue taking the medication within 12 months of starting. So we were interested to see what happens to people's body weight after the medication stops. To look at this, we identified studies that had given people medication for weight loss and, importantly, followed them up afterwards, after the treatment had stopped. We focused on any medication, those that had been licensed previously and since discontinued, right to those that are being prescribed now. In total, we identified 37 studies that had given people weight management medication, and also, given the focus on semaglutide and tirzepatide, we also did a subgroup analysis of studies that had just focused on these, and there were 6 studies in total that had used semaglutide or tirzepatide.
And what did you find?
So when we look at people taking any medication, we find that they lose 8.3 kilograms during treatment, but then within the first year after stopping, they regain 4.8 kilograms, and they're estimated to return to their baseline body weight within 1.7 years after stopping taking the medication. When we focus on semaglutide and tirzepatide only, people lose more weight. They lose around 14.7 kilograms, but then they regain 9.9 kilograms then within the first year of stopping. It's important to note here that we only have 12 months of follow-up for people who are given semaglutide or tirzepatide, but we were able to produce a projected estimate that people will return to baseline weight within 1.5 years after stopping medication. We also looked at different cardiometabolic risk factors with that. So things like HbA1c, fasting glucose, blood lipids, and blood pressure. And we found that they also decreased with treatment, but returned to baseline virtually in parallel with weight regain, such that they were back at baseline within 1.4 years.
So that's really interesting, because I think that's been one of the concerns when as a GP, I sometimes talk to people who are interested in starting these medications, and we all there's this kind of sense that the weight comes back once you stop taking them. But it's very helpful to see this kind of quantified. I don't think I've seen this kind of quantification before. And I think this has implications for, the way we counsel people about taking these medications. And also the way, there's a big plan within the NHS where they're being rolled out and launched. And I guess this influences how we might think about the kind of cost effectiveness of these medications as well. So can you just talk to us a little bit about what do you think are the kind of clinical implications for an individual patient?
I think you touched on the key implications there. It's important that people going into treatment are aware of the risks. At the minute, 90% of the people in the UK who are taking this medication are accessing it privately and paying for it for themselves. So they now have this information of the rapid weight regain after treatment stops to make their own informed decisions about this. And also for clinicians who are counselling patients about the best approaches to manage their weight. Clinicians can now have fully informed conversations with patients about the benefits of these medications. They're clearly very effective for weight loss, but also the very real possibility that people will regain much of the weight after the treatment has stopped.
And do we know if, because you mentioned the weight regain and also then that the improvements that have been shown in studies in things like blood pressure and lipids and glucose, that you found that those also are reversed to an extent when this medication is stopped. Do we know much about whether are these medications just useful for that window that people are taking them? Do those effects last? Is that something that needs to be studied further?
Yeah, that's one of the key limitations, I think, to the study. So we do find that those cardiometabolic risk factors return to baseline within 1.4 years of stopping any medication for weight loss. It's important to caveat that is not just for semaglutide and tirzepatide. But what we don't have is data beyond that to know whether this has any changes for hard outcomes. So those long-term real-world data are going to be really helpful.
And that, I guess, is just a limitation of the follow-up of the trials that are included in your review, that the follow-up, these new medications, that follow-up, I guess, is happening now and isn't there at the moment?
Precisely, yeah. They just haven't been around for long enough for us to have this long-term data. Of course, they've been used for diabetes for many years, but at these doses where they're inducing such weight loss, we don't have the long-term follow-up yet.
Which I think is also important in the counselling of patients as well, is that, these are still live questions, because I imagine lots of people will have, these kinds of questions. Another thing that I thought was really interesting is, what did you find about the rate of weight regain in respect to the amount of weight lost? Did that have any bearing on how quickly or not weight was regained?
Yeah, so we had previously conducted a similar systematic review where we looked at the rate of weight regain after behavioural interventions, and we found that the rate of weight regain was dependent on the amount of weight lost during treatment, such that more weight lost equals faster weight regain. And that was also consistent across our review, where we found that the more weight that was lost with medication also resulted in faster weight regain.
Interesting. And it's interesting that you bring in the sort of behavioural interventions, because I think one of the other notable findings was that the weight regain after stopping medication seems to be faster than after you stop behavioural programs. Is that right?
Yeah, so because we had this data from the previous systematic review, we took the opportunity to do an indirect comparison of the two. So we found that people who took medication lost more weight compared with those who took part in a behavioural program, but the weight regain was much more rapid after medication compared with people who had taken part in behavioural programs. So after medication, people were estimated to return to their baseline weight after 1.7 years, whereas people who had finished a behavioural program weren't estimated to return to baseline until just under 4 years. And as I said, the amount of weight lost is predictive of how fast people regain the weight. So we thought that perhaps this difference in weight regain could be explained by the fact that people just lost more weight by taking medication. So we did a further analysis where we broke down the amount of weight lost into averages of 5, 10, and 15 kilograms. And we found that, as I said before, more weight loss equals faster weight regain, but we saw consistently faster weight regain with medication, regardless of how much weight was lost.
That's really fascinating, because I think, just in thinking about how these medication works, I guess you could sort of say, well, these behavioral programs might be teaching or, involving skills about your dietary intake, movement and exercise, as well as kind of, I don't know, other techniques that might help manage the way you eat and how you eat. But these medications as well, I think there's also some uncertainty about whether they affect they might have some long-term effect as well, but I guess that's not borne out by the evidence.
Yeah, I think you've touched on it there. When you're part of a behavioral program, you're often taught ways to manage your hunger while you're losing weight, whereas the medications work to remove or dampen those feelings of hunger. But when the medication stops, if you haven't been given coping skills to manage the feelings of hunger when they come back, then there's no recourse to help manage the weight after treatment. Whereas those who might have finished a behavioral program can continue to implement the different skills that they've learned during the diet.
Well, let's look at this now from a kind of health policy perspective, because we talked about health systems around the world, not just in the UK, but in the UK also, are funding these medications and probably in a lot of places trying to expand the funding of these medications. But these drugs are expensive, if we're thinking about semaglutide and tirzepatide. And if the benefits, can be reversed so quickly upon stopping, how do you think health systems should consider the value of these medications? Or do they need to be prescribed lifelong? How do we kind of grapple with that?
I think one of the implications of this research is that we can at least reopen the discussion around the cost effectiveness of these medications. Speaking specifically about the UK, when licensing these medications, NICE perform cost-effective analysis before they can be licensed within the NHS. They did that using their standard process with the data that was available. And they assumed that people would regain their body weight over 3 years, and found that these came in at a cost of £16,000 per QALY. Just to note, the NICE willingness to pay threshold is £20,000. So as long as it comes below that, they're considered cost effective. But when they performed a scenario analysis and assumed people would regain weight over 2 years, they came in at £21,000, so just exceeding that threshold. So I think it would be interesting, at least, to revise this model with the new weight regain data that we have. Previously, NICE have done all this work with assumed weight regain. We now have the hard data to show that it's faster than those assumptions. So I think at least it reopens the conversation for us to revisit those models.
It's something that could and perhaps should be looked at again. Actually, I've just thought of one other thing that I want to ask you, which is for people who are already taking these medications, I guess there might be some concern now about, well, when I stop, what's going to happen? Is there anything available for people to help, I guess, soften the landing or provide support? What resources might you suggest, or strategies might you suggest for people who want to come off but are now worried about weight regain?
So one of the other things that we looked at in our review was the relationship that behavioural support during treatment would have. And we found that intensive behavioral support during treatment with the medication helped people lose more weight. So people provided with intensive support lost 4.5 kilos more than those provided with very little or no support at all. But unfortunately, we found that behavioral support during treatment or after treatment didn't affect how fast people regain the weight afterwards. So we don't really have a clear picture of what needs to happen at the end of medication or even during treatment with medication to prevent the weight regain. Clearly, some people will effectively keep the weight off. Some people will regain it faster than what we found. That's the nature of averages. What we need to do is find out what's working after medication. One caveat to the work that we've done here is that we have synthesized data from clinical trials, and the type of person that takes part in a clinical trial and the environment of a clinical trial is very different to that of the real world. People are often more motivated to lose weight, and there's a lot more support. You're being monitored the whole time that you're on the study. In some studies, people were given monthly meetings with dietitians or physicians, and that is very likely different to what's happening in real world settings, both in the NHS and for people who are accessing the medication privately. So what we need next are real world assessments of how these medications are being used in the real world. That goes for the clinical characteristics of the people who are using them in the NHS and privately, the scale of weight loss that happens in these settings, what type of behavioral support is being provided to people who are being given the medication, and we can continue to monitor discontinuation rates and also weight regain for those that stop taking it.
And that article, Weight Regain Following the Cessation of Medication for Weight Management, is available via open access on bmj.com. Lastly, we turn to the ongoing health catastrophe in Gaza. The international charity Médecins Sans Frontières, or Doctors Without Borders, is the BMJ's choice for our charity appeal this Christmas season. They've been providing life-saving care for Gazans whilst acting on their principle of témoignage, or bearing witness, to the suffering that they are seeing. On the 30th of December, 37 NGOs, including MSF and Oxfam, were told by Israel that the registrations necessary for their aid workers to operate in Gazan clinics and hospitals would expire the next day. They now have a 60-day window to end all operations in the Gaza Strip and the West Bank, including East Jerusalem. Overall, around 60% of Gaza's field hospitals are run or supported by such international non-governmental organisations. As of the time of recording for this podcast, Wednesday, January the 7th, this order has not been rescinded. Our reporter, Elizabeth Mahays, is covering this story and tells us more.
My name is Mohammed Abu Mugaisib. I joined MSF 22 years ago as a general practitioner supporting the mobile clinic activities and mental health activities. Then in 2007, I became the medical referent for the MSF programs, medical programs in Gaza.
That's Mohammed, a Palestinian doctor who serves as MSF's Deputy Medical Coordinator in Palestine. I spoke to him in late November about the devastating conditions Gazans are suffering through this winter. Widespread heavy rain, flooding, and frigid temperatures, alongside continued restrictions on vital aid entering Gaza, have left the territory in a desperate situation. Gazans, their homes levelled after years of Israeli bombing, have few options except to attempt to survive the freezing conditions in inadequate tents and makeshift shelters. Respiratory infections are widespread, and the rains have caused sewage to overflow. It has been reported that at least 25 people have died in recent weeks as a result of the extreme weather conditions, including a 29-day-old baby who died from hypothermia. This is the state of healthcare in Gaza, and it's only set to get worse. Israel has now reportedly banned dozens of international aid organisations, including MSF, from continuing their work. the NGOs have been given just 60 days, or until the 1st of March, to leave Gaza. I asked Mohammed about the sense of duty doctors in Gaza feel, especially in the face of threats to their lives and the horrendous conditions that they're living and working in.
I mean, the doctors and paramedics who are working in Gaza, they are really heroes in terms of heroes. Because, first of all, they are part of the population. So they are suffering the same as other the population is suffering. So they have families who are displaced in shelters. They are under risk going and leaving the hospital and leaving their family behind. They are on time. They are stressed because they know that at any moment they could have in the ER members of their family. And it happened that our colleagues, they were working in the operating room and they received their children dead and their family have been critically injured. And in addition, with limited, of course, means to work. You don't have everything. You don't have the proper enough painkillers and anesthesia drugs. You don't have the enough surgical tools. The capacity and the overload of work. They could operate 2 to 3 patients in the operating room or operate patients on the floor. So patients in Gaza during the war, I never saw this in my life, that patients who need surgery were waiting in queues to have their surgery, and patients even who need intensive care unit were waiting in queues to be admitted in the intensive care unit. And finally, of course, the starvation. What has been the population suffered, it was as well the medical staff. The medical staff were starved. They were having an acute hunger. They were completely exhausted, tired. There was no food to buy. In the market. So they were with really no energy to, but still they were coming, as you said. And even with the warnings from the Israeli army to evacuate the hospital, they were refusing. And I think that's ethically right. They cannot leave patients behind. You have, not all the patients can leave and walk. You have patients in the operating room, you have patients in the intensive care unit, you have babies in the incubators, you have patients and even in the ward that cannot move. So you cannot leave the patients and who are in the hospital and just obey the orders and leave. So they had this ethics to stay, and the consequences that they were arrested and they were tortured and some of them have been killed because of this.
On New Year's Eve, December 31st, Israel revoked the operating licenses of 37 aid groups, including MSF and Oxfam, for failing to comply with new registration requirements. The new rules mean that international NGOs operating in Gaza and the West Bank must provide Israeli officials with detailed information on their Palestinian staff members. Fearful for the safety of their staff, aid groups are reluctant to comply. Israeli officials have alleged that some NGOs, including MSF, have employed staff with links to armed militants, something that MSF has strongly denied. Here's Claire Sanfilippo, MSF's Emergency Coordinator for Palestine, speaking about the situation.
As of December 31st, MSF is still awaiting renewal of its registration to operate in Gaza and the West Bank under new Israeli requirements, including staff lists. Despite months of engagement, no clear criteria or safeguards have been provided. On December 30th, Israeli authorities publicly accused MSF staff of links to armed groups. MSF takes such accusations extremely seriously and would never knowingly employ anyone engaged in military activity. Such unsubstantiated public claims put humanitarian staff at risk and undermine life-saving medical work. The Palestinian health system is decimated, essential infrastructure destroyed, and people struggle to meet basic needs. People need more humanitarian aid, not less. If MSF and other international non-governmental organizations lose access, hundreds of thousands of Palestinians will be cut off from essential healthcare. MSF currently supports 1 in 5 hospital beds and 1 in 3 births in Gaza. In 2025 alone, we provided nearly 800,000 outpatient consultations, treated over 100,000 trauma cases, performed 22,700 surgeries, assisted more than 10,000 births, and distributed nearly 700 million liters of water. Reports suggesting that MSF has failed to comply with registration rules are inaccurate. We have been fully engaged since July 2025 and submitted most of the required information. MSF continues to seek dialogue with Israeli authorities so that we can deliver vital and critical health services and support Gaza's decimated health system.
More than 500 humanitarian workers have been killed in Gaza since the 7th of October 2023, while at least 1,700 health workers have been killed as of the 6th of October 2025. That's around 2 a day, and healthcare facilities have also continually come under attack by Israel. Many Palestinian doctors have also been arrested and taken away by Israeli forces. I asked Mohammed about the doctors who have been detained by Israel and the horrifying reports of torture and in some cases death that have come to light. I also spoke to him about MSF doctor Mohammed Obaid, who is still being held by Israel, and whether there have been any updates on his situation.
Until now, we don't know nothing. I mean, now it's followed by the, lawyers that MSF is as well following with. But Dr. Mohammed Obaid is an orthopedic surgeon that has been working with MSF in the reconstructive unit. He's a very experienced orthopedic surgeon, and he didn't want to leave the hospitals because, you cannot ask a doctor, an orthopedic, in a trauma surgery, in a war zone, to leave his patients and leave the hospital. That's the only crime that doctors and like Dr. Mohammed Obaid has been charged of, not leaving the hospitals after the order by the Israelis to leave the hospitals. And I think that has to be, of course, investigated later. And the doctors that has been luckily released, they have horrible stories about the treatment inside the prison, and fortunately, physical abuse and all of this kind of things. Look, before leaving actually Gaza, 2 days before leaving Gaza, I will describe to you the hospital that Nasser Hospital is one of the biggest hospitals in the south, in Khan Yunis. So in the 2 days before I left, I went to say goodbye to the team. That I'm leaving, and when I entered Nasser Hospital, the MSF unit, patients were on the floor. There was no space. Patients were on their mattresses, just on both sides of the corridors. It was more than 200% of occupancy rate. It reached in Nasser Hospital. Patients were shouting, crying from pain. The smell of the infected wounds and blood. Obviously, I couldn't really stand for more than 5 minutes in the wards of MSF, even with all our capacity, with all our means. But the number of patients who were injured were high. Since the declaration of ceasefire, there was always been airstrikes and bombing that didn't stop. A lot of people have been killed and injured. A majority of them, 60%, children and women. So, there is no excuse about targeting any kind of military Palestinian fighters or whatever, Hamas. No, it's mainly obviously children were the main target, and which we reached now more than nearly 20,000 children killed, and 10,000 of women have been as well killed. So it's and the aid, it's still under restriction. Yes, aids are entering, but there is always restrictions. There is what is called dual use. You cannot bring all medical items because they say, okay, this item is a dual use, so you cannot prevent it. So it's really the ceasefire didn't improve the situation. The people still are actually in the tents and their shelters, so they didn't go actually back to their homes because there is no homes anymore. The Gaza has been destroyed. Plus, now they are they are all living in a very tiny region. I mean, when you see the map, there is the yellow line that takes all east of Gaza Strip. So the people are squeezed only on the west side of Gaza, which Gaza before 7th of October was one of the dense areas in the world. I mean, with 2.2 million people living there.
As of the time we're recording this, the 7th of January, MSF has said it's exploring all options when it comes to continuing its work in Palestine. The charity has applied for re-registration and is actively engaging with Israeli authorities with the hope of making this happen. Their application is still pending. Palestine is just one of the countries where MSF is currently working to provide vital and life-saving healthcare. You can read more about their work in places like Sudan and Nigeria on the BMJ's website. That's bmj.com.
A reminder that MSF is our charity of choice for the BMJ Christmas Appeal, and you've heard how important their work is. There is still time to donate to support them, and we've added links to the podcast notes to do so. Please give if you can. That's it for this week. We'll be back soon with more medicine and science from the BMJ. Until then, I'm Cameron Abbasi. Thanks for listening.